Hello, everyone, and welcome back to BSchool Backstage. Today, we have with us Professor Kamalini Ramdas from London Business School, who talks a lot about overall research, about how we can deliver better services and innovate specifically in the services to deliver better care, better access, and better services overall to our people. Kamalini, welcome to the show.
Thank you, Abhinav. Delighted to be with you.
Thank you. So let's start with how humans interact. You've talked about this in the past quite a bit, and there's many counterintuitive and thought-provoking ideas there. Could you talk a bit about your learnings from studying how humans interact and how, in general, this applies to most or all of us?
Definitely. In my view, how people interact is absolutely fundamental to how we communicate with each other and also how we as humans achieve all the things that we do achieve. One of the things that I have noticed along with my colleagues over years and years of studying different organizations and trying to identify which organizations are highly innovative is that very often just the way they interact can fundamentally change how innovative they are. And it is interaction with clients or customers. It could be interaction within the organization with different people, employees within the organization. It could also be interaction between one organization and another organization, which are jointly involved in providing or solving a problem for a particular customer or client.
So about humans in particular, what have you gleaned from that as to how we interact in all these different settings?
We often assume that a particular type of interaction is going to happen in a particular way, because we've been around forever, right? So there are certain norms about how particular interactions occur. So if you think about going to the doctor, the typical image that might come to mind is that your interaction with your doctor is going to be one-on-one, it's going to be in person and private. But the reality is that all of these are just assumptions. We found during COVID, for instance, that the in-person was completely thrown out of the window, and all of a sudden you had the telehealth type of interaction. And the reality is that the one-on-one and private are also assumptions. And if you, on the other hand, think about education, in education, you make a very different type of assumption that the way education is going to be delivered is one-on-many. Typically, it's going to be in a classroom. It is not this one-on-one private. And again, often pre-COVID, it was assumed to be in person, but I do remember literally, was it the 15th of March 2020, when we had a faculty meeting, and then an email went out, it was a Friday, an email went out later that day saying on Monday, you're going to be teaching on Zoom. And lo and behold, the entire faculty at London Business School and faculty all over the world who had never, I had done one remote teaching experience prior to that, but we all suddenly just jumped on Zoom and we taught. But earlier than that, there was that assumption that, hey, this is done in a particular way in the classroom.
I really appreciate the articulation of how medical services are offered, and we assume that has to be offered in a particular way, and how education is also offered we think of it as it being offered in a one-to-many format, but even that can change overnight, and how we should possibly not assume how interactions of humans have to be codified in these buckets, which also brings me to the interesting point that you have made across your talks about shared medical appointments. And you talk about how we have to do things differently, especially when we're offering services. Could you talk a bit about the idea of shared medical appointments and how can we think about innovating or rethinking how we deliver services?
Definitely. And prior to jumping into shared medical appointments, I'll also highlight to you that throughout the past 20 years, my research interest has been in identifying what I like to describe as radical innovation And radical, basically, all I mean by that is that there would be a major improvement in the quality of the outcome, and very likely together with that, a quite substantial reduction in cost. So the value improvement is both from better quality and very often from better cost. That's all I mean. I don't mean something academic about what the radical innovation is. And so I'm always on the lookout for these types of radical innovations, and in particular the ones I'm most keen on are the ones that reduce some form of inequity, whether it is lack of access to healthcare, lack of access to information, lack of access to education, lack of access to jobs. So those are the kinds of things I'm broadly interested in. I was, prior to being at London Business School, I was a professor at the Darden School at the University of Virginia, and probably in 2006, a colleague of mine, Elizabeth Teisberg, who was a strategy professor there, said that she had come across a woman cardiologist at the University of Virginia hospital system, Amy Tucker. And Amy Tucker was contemplating starting to offer a shared medical appointment type of setup. And so how this was going to work is that she was a preventive care cardiologist. You wouldn't be going to her if you were having a heart attack, but rather if you had had some previous heart issues, or if you had high blood pressure, obesity, etc. And typically you would go every 3 to 6 months for a checkup. And the way this would work is if you, as a patient, called up Dr. Tucker's office and said, can I get my one-on-one with Dr. Tucker? Typically, the assistant who answered the phone would say, yes, you can. It's going to be 6 to 8 weeks to get that. And then the assistant will say, would you instead like to come for a shared medical appointment, which is going to be tomorrow or this week? And what's going to happen is there will be other patients like you in the room with you, with Dr. Tucker. However, she's going to give each one of you a one-on-one. So she will diagnose and prescribe medication for each one of you, but you'll be able to all listen to what she's saying to the other person. So this is a shared medical appointment. Now, when I heard this, I thought, oh my goodness, this is a potentially radical innovation. It's pretty obvious that the doctor would very likely save time. And the reason is that in Dr. Tucker's office, the one-on-one was a 30-minute appointment with a patient. They were going to do the shared appointment as 90 minutes with 6 to 10 patients. And if you think about what happens in the 30-minute one-on-one, some of it is tailored to the particular patient, such as, the exact dosage and the exact medication. But a lot of it is things like you need to eat better, you need to exercise, etc., etc. And what happens in a shared appointment is that all of that common guidance doesn't need to be repeated again and again and again, which is also quite tiresome for the doctor because they're doing that all day long. And instead, what you can do is, by saving on that time, you can have higher level conversations. You can go deeper into certain issues. And so the doctor can offer more guidance. And so clearly there's cost saving, but what I found even more interesting is that when Dr. Tucker started to offer these shared appointments, their clinic was finding that the patients were loving it, and they were in fact, if you look at the outcomes in that clinic versus that wasn't the only cardiac preventive care clinic in the UVA health system. There were other clinics, and they were finding that weight loss was significantly higher in the shared medical appointments clinic than in those other cardiac preventive care clinics. And so this means that the patients were somehow learning in that shared appointment that they need to reduce their weight and managing to reduce their weight. So it was an outcome improvement and a cost reduction as well.
That's very interesting. And I find it fascinating that at the cost of quote unquote confidentiality of patient information, it turns out that patients are actually valuing the community experience that they're getting. And because they also see others going through the same experience, they're more motivated for things like weight loss, which is pretty counterintuitive. How do you think that we could possibly apply this insight of just in one particular field of shared medical appointments to generalizing this to a broader array of services that businesses and individuals offer across spectra? And I understand that it's pretty difficult to generalize, but what are the insights that we could sort of extract which might help us of that?
Definitely. There's nothing specific to medical services in this concept. It can apply across the board to many different kinds of services. And in fact, my colleague Elizabeth Teisberg and Amy Tucker and I wrote an HBR article several years ago highlighting exactly this idea that you are talking about. And just to give an example, when I first described this idea of shared medical appointments to Saul Klein, who is a VC in London, and at that time he was with Index Ventures, which is a very large venture capital firm in the UK and in the European horizon. And the moment he heard that idea, he said, "Oh my God, we can use shared appointments idea, the concept, in how we advise startups." Everybody knows that a lot of venture capital money gets put into startups, but just as important as the money is the advice that those startup firms get from VCs. And you'll often have a senior VC who is advising one particular startup founder or the startup group one-on-one. And what he said is, we can bring a bunch of startups together from East London, which is vibrant with startups, and we can advise them all at once. And I asked him, how can you do that? Wouldn't they be competing with each other? And his point was, there are enough startups that you can find subgroups such that there wouldn't be any competitor type issues, and many of them can learn from each other because there's a lot of things that are common to all startups.
Yeah, I totally appreciate that. The fact that this insight is not in fact specific to one field. And, I'd love to read the HBR article to get more insights over there, and would also recommend that to the viewers. But that's something to think about more. Let's talk a bit about your journey as well. You did your bachelor's in Delhi, you were in the US, you went to Wharton, and now you're in London. Could you talk a bit about the education systems in these places, and maybe, the few key insights that you've gathered from this cross-cultural experience?
I have, in fact, lived in these three different continents, and I think a lot of my education was quite a while ago. And what I can share is that I'm very excited to see that now education systems all over the world are becoming more diverse in the clientele, so the student body, and also in the faculty body. And so at London Business School, when I first came to London Business School in 2008, I was stunned to find that in that year, I believe 93% of the student body was international. And in the US, the amount of international students was lower at that time, and it is still lower, although increasing. And the other thing is the number of women, or the percentage of women. We're seeing dramatic improvements in the percentage of women who are in various programs, MBA program, executive MBA program, masters in management, and at different universities. And in India also, same thing is happening. In the US, the same thing is happening. And similarly, we're seeing more women and more diverse representation of different ethnicities in faculty. So this is, I think, a great thing that these things are now actually something that people worry about. I see very often nowadays that when we are recruiting a faculty member or a student, they want to know how diverse are you? They're asking that question, which many people were not thinking of asking many years ago. All that said, I feel that there is still plenty of opportunity to do more to ensure that there is equity, and diversity is just in the end numbers. But just having numbers of different ethnicities doesn't mean that you've actually got equity. And I want to highlight a very interesting research paper that I saw presented at a conference on discrimination at the University of Chicago, which was run by an economist, Marion Bertrand, and her colleagues. And the presentation I saw was by Soumitra Shukla, who is an economist who got his PhD at Yale. And he looked at data from Indian engineering schools. And the particular name of the school is not mentioned. But what he was looking at is, just like in many parts of the world, there's reservation in India, so that disadvantaged castes have a percentage of seats that are for them. And now when recruiters come to universities to recruit, what he finds through a very systematic analysis of his data is that in some of these job recruitments are 6 or 7 stage processes. So in the early stages, where it is just about sorting through resumes or about some online task, there you don't see any discrimination. And conditional on the quality of the resume, you are finding that people of different castes are equally likely to get through to the next stage. But when it comes to the final stage of the interview, where it is in person, and then some of the things that people are looking to basically see if there is a good fit, will this person fit well, that's where you see that the disadvantaged castes are not making it conditional on everything else being equal as far as the quality of their resume. So there's a long way to go.
There definitely is a long way to go. But do you think that, because on one hand, we also need the subjective element, don't we? Because, humans are also better equipped to evaluate other humans than perhaps technology is today. Do you think, what's the holy grail? What's the end state of a process like this, where humans are fundamentally subject to, bias and prejudices, which are preconceived? So how do you see that evolving, especially in the context of DEI that you talked about?
I love data, and I think that one thing that can help tremendously is showing people data. When you show people data, we're all biased. We are, every one of us, I feel has some bias or the other, and that's how we think. But when you make people aware of biases, then they would, to some extent, try to look out and reduce that bias. And there are some cases where people learn, because when you are biased, you may make the wrong decision. And so sometimes in some settings, I've seen that if you have more experience with a particular type of interaction, then you will be less likely to be biased, especially if being biased is resulting in your having made the wrong decision for yourself. But showing data can also help.
Yes, absolutely. I think that sort of sums up the whole issue there.
And the other thing is, I feel that, if you, I think that we can change who we are, and there's plenty of research also shows that there are 2 types of mindsets. There's a growth mindset where people believe that they can actually mold themselves and change. It's not like I'm bad at math. I might become better at math, versus a fixed mindset. So that and this mindset can be changed. That's also what research shows.
Absolutely, that definitely makes sense and helps me understand this whole idea much better. Let's talk a bit about your journey teaching as well. There's different types of teaching at different business schools. At Harvard, we have the case method. At Stanford, it's a bit different. At other business schools, it's particularly different as well. At NCR and LBS and so on and so forth. Would love to understand what is the LBS way of teaching and how you approach teaching business education, and particularly things like innovation and radical innovation to your classes?
Yeah, I'd love to talk about that. And I have had experience both at Darden, which was a very much a case method school, and then at London Business School, where it's a mix. Some faculty teach more case method, some are teaching more lecture. And then at, when I was a student at Wharton or in my undergrad, it was more lecture based. One thing that I feel in my own teaching, I feel it is extremely important for it to be hands-on. And I'd like to go back to that discussion we had a little while ago about the shared medical appointments, because when it comes to talking about radical innovation in my business model experiments class, I definitely like to talk about shared appointments, but I also like to share with them the history of how even my research evolved. And I very much like to bring my research into the classroom. When I first saw the shared medical appointment concept back in 2006, and I could see that the data at the University of Virginia Hospital was suggesting that you can improve outcomes and reduce cost. However, I realized that the comparison that had been made was not a really scientific, rigorous comparison, because naturally, some patients had selected to go for the shared appointments, and others may not have. And maybe it was the more motivated patients who decided, I'm going to go for the shared appointment and spend the 90 minutes. And so the first time I saw it, I thought to myself, this has to be studied in a rigorous scientific way, which means randomized controlled trial. Now, after COVID, everyone understands, vaccine trials, etc. But this would have been a trial of a service in which one would want to randomly allocate some patients for any particular disease to go for the shared appointment and others for the one-on-one appointment. And I wanted to do this. So then I started approaching hospitals in the US, because I was teaching in the US, and I didn't get any interest. And then I came to the UK and I started asking around people. And again, very little interest. And several doctors thought that it was really a no-go. What do you mean? How can patients be brought into a room together? You're going to violate confidentiality. Now, the way it works in the US for those who are using it is that you get to sign a HIPAA waiver. So, the hospital has taken care of confidentiality. But at any rate, I got to meet Lord Darzi, Ara Darzi. So he had at one time been the Parliamentary Undersecretary for Health. And I wanted to talk to him about shared appointments. And when I asked him, Lord Darzi, do you think that shared appointments could be used for the NHS? He looks at me across the table and he says, Kamalini, I'm a colorectal surgeon. I see zero use for shared appointments. Which was interesting. But then even more interesting, a few weeks later, he messaged me and he said, you know what, I think it can be used pre-surgery and post-surgery. And so, but I was still looking for a hospital that would be willing to do a randomized controlled trial, and I had no luck. And several years ago, I was at Davos and met the CEO of IDEO, which is a major product development consulting firm, and he said, why don't you talk to the Arind Eye Hospital in India? So then I emailed Tulsi Ravella, executive director of the Arind Eye Hospital. Tulsi said, and I just said, look, can I come to your hospital? And you're a very innovative place. I want to see some of your super innovative processes. The thing that they are very well known for is that they made cataract surgery like an assembly line operation. Usually cataract surgery is done by one surgeon. The way they do it, they'll have two patients in the same operating theater, and the surgeon does only that part of the surgery which only the surgeon has the experience and the skill level to do. And all of the other tasks are done by young women who have a high school degree. So the opening up of the eye, the stitching up, all of that. And so I'd said I'd like to come and see that. I'm in general interested in radical innovation. And guess what Tulsi said? He said, you're welcome to come, but you're coming from the West. You need to tell us something new.
That's pretty fair.
And think about it. Arind is the biggest eye hospital in the world. They are treating 2/3 of the eye care volume of the NHS at 1/100th of the cost. Think of the spirit that they are wanting to learn something new in every interaction. So I go to Arind, to their Pondicherry hospital, and I thought that I'm probably going to be talking to them in a conference room, but just somehow, some sixth sense, I had some slides with me. And then they ushered me into this big room with about 50 or 60 people. This was in 2013. And they had 10 big screens at the back of the room, and they had their top brass from their 10 other Arind hospitals, all on those, it was a video interaction. And so, right. And so I told them about shared medical appointments. And then after that, Dr. Venkatesh, who was the chief medical officer of the Arind Pondicherry Hospital, said, I think we can use this for glaucoma. Not for cataract, which is a one-off, but glaucoma is a lifetime disease. Once you've got glaucoma, your eyesight is deteriorating. You cannot reverse that. The only thing you can do is reduce the rate of deterioration by taking eye drops, but you need to take them very regularly. And so then his point was that that's going to, maybe patients will be more motivated to take the eye drops. And then the thing that I like to share with the students, whether MBA, executive MBA, executive education, so it could be executives, is that what you have to look at is how did this incredibly huge, vast organization innovate? And what they do is baby steps. When they said, we'll do this, I was delighted and I said, okay, we can design a randomized control trial for you. But they said, no, we don't want to do any RCT. I said, okay, let's trial it with some doctors. They're like, no, we are running like a factory. They first trialed it with a counselor, where they brought a counselor and a group of patients who were waiting anyway, because when you go for an eye appointment, often you're waiting between stages. So the counselor met this group of patients in a room. I happened to be there. And what I saw is that each patient was being asked by the counselor some questions, and they were asking about their meds and all of that. Patient number 3 takes some meds out of their pocket and asks a question. Now, the moment patient 2 saw patient 3 taking the meds out of pocket, patient 2 immediately grabbed some meds from their bag, because suddenly they realized they have a question as well. So the interaction.
Yeah.
Right?
How humans interact in these
exactly.
situations.
Yeah. And then the last patient was a woman, and she said, I've had glaucoma for 20 years. Now, the first patient almost jumped out of his chair and he said, can you see? And she says, yes, I can. And I've been taking my eye drops every day, twice a day for 20 years.
Yeah.
You could literally feel how important her saying it was for the other patients, because the counselor says that all the time, the doctor says that all the time, but who gives a piece of information matters.
It almost feels like first-hand anecdotal evidence is more impactful than RCTs or empirical evidence over a long period of time.
Actually, Arind does care about the RCT, but what they were doing is baby steps. They didn't want to jump into any RCT. They did this. Then they said, okay, this seems to work. So then there was a pilot on a weekend, which in the pilot didn't go very well, because in the first pilot, 24 patients were in the pilot. And the doctor said this felt like a wedding, which was a complete diss, because you know what Indian weddings are like.
Of course.
But then they had taken feedback from every patient. So that's the beauty of their step-by-step innovation for a very radical innovation.
Yes.
And then with all that feedback, they said, okay, let's try it one more weekend. And that time there were 8 patients. It went really well. So then I was thinking, of course, researcher me, I'm thinking, okay, RCT, no. Then they did for 1 year on Friday afternoons, because Friday afternoon is their lightest day of the week. So they tried the shared appointments, and they decided that over that 1 year of learning that groups of 5 would be better. And then we designed and ran a 1,000 patient randomized control trial with 2 of the doctors at Arind and Ryan Buell, who is a professor at Harvard Business School, who I invited in to work with us, and Nazle Sonmez, who was my PhD student. She's now on the faculty at ESMT in Berlin. And so it was all of that, baby steps before doing the trial, from which we got some really interesting results.
It sounds like the teaching method that LBS, or for that matter, you have in your classes is almost a cross of the case method, but with these nuances and really bringing in your research into the classroom and making that practical and accessible for all. It's not purely on the case method side and not purely on the, shall I say, the research and practical aspect of it side. It's sort of blending the two. And so you have a story with evidence and anecdotes, and all of that becomes very impactful, which sounds to me very credible. You talked about product design and development, and I'd love to understand, and you mentioned that you met the CEO of IDEO. I'd love to understand how, in the case of services in particular, when services are effectively commodities, how can businesses distinguish themselves in situations like that? And I remember reading one of your papers in which you even talked about water. How could services be distinguished on that basis when the service itself is very commoditized?
I think that a service like water is very commoditized when you think about the West or the affluent in the global South. But in fact, a large percentage of the world doesn't have clean drinking water at all, and it is far from commoditized in that setting. And in fact, in my innovation elective on sustainable business model experiments, even this term, there was a team thinking of ways to bring water to underprivileged people in developing countries. And you can see that, and just to challenge that water, some things that we assume are commoditized are not. The Tata Swachh, for example, was going to be a water purifier with rice husk in it. And Tata is an incredible brand. And the Tata Swachh has not really taken off. And there are other examples of water purifiers that have failed. So I think a lot of getting things right is about really understanding the target market and figuring out how are you going to meet their needs, because and at the right cost. And what I like to tell my students and to tell executives is you just have to experiment. I'm not a fan of, especially in teaching innovation, I'm not a fan of doing a lot of internet-based and now ChatGPT based research and then creating these spreadsheets with look, this is going to be our revenue coming in year 1, year 2, year 3, and we're going to break even. That's great. That's important to know, and they learn that in other classes. But when I'm teaching, I'm much more interested in, can you really understand the consumer needs, and can you do real transactions? Now, what is a real transaction? A real transaction doesn't necessarily mean it's a paid transaction, but you need to get people to actually use your service. And just as an example, a couple of years ago in my innovation class, there was a team and they were saying that there's plenty of students who just don't have time to cook a meal for themselves. And then there are other people who might be living in the same apartment building who are cooking for more than one person. So we can match these two and create a marketplace. They had created these very pretty looking wire screens of an app, which, if you click here, you will see this, and you click there, you see that, and all of this. And it's a 5-week class. And in week 4, they're showing me, and I'd said right from the beginning, real transactions. Week 4, I'm seeing these beautiful, highly polished looking app screens. And I said, I'm sorry, but your grade depends on it. You are going to do real transactions for the final presentation 1 week from now. I don't need any pretty app. You can do it using a Google spreadsheet, but you show me some real transactions. And guess what? 1 week later, they had, just through a Google spreadsheet, they had found a bunch of students who needed a meal, a bunch who were willing to deliver, and they had actually charged. And so they had done these real for a particular price transactions. And when they presented that, the venture capitalists who were commenting on the student presentations, they were impressed because you got some real data by doing that. And so that's a big part of what I like to do. There was a team in the past where they and I also share with you an amazing alum of LBS who came and spoke to my students, Vinay Gupta. He said that every piece of unused capacity is a business model waiting to happen. Now, one team in my class, they said that, look, restaurants often have last-minute cancellations, and people want restaurant booking at the last minute, so let's make a portal to connect the two. And I said, you can do you have to do a prototype in my class. And in some of their earlier prototypes, what they did is, because they didn't have a way they weren't really connected to a restaurant scheduling system. So instead, I think they just bought some bookings. They may have told some friends of theirs that, look, if no one shows up, then you please go and eat a meal in that restaurant. But they at least tested the customer-facing side, because they're saying that there's a cancellation here. Do you want a last-minute booking? And in the end, well after my class, this team raised, $1 million or more, and they created this product, and then it was bought by another company. But I think that starting, when you're wanting to innovate, many people just feel like they cannot start to experiment. You have to. And look at what Arind does, baby steps.
I think that answers the whole idea of, or rather the preconceived notion of services being commoditized very effectively. Because if you really dig deeper and you have all these examples with you, services are not really commoditized. And as you mentioned and added so much more flavor to it, that every unused capacity is a business model, business innovation that is waiting to happen. And we can see that across anecdotes and these very specific problems that students or colleagues of yours have focused on, which is quite incredible. I think just one last question, and then it would have been an absolute incredible conversation with you. I want to talk about the trends that you see in healthcare, the economy, and largely the services industry looking ahead. What do you see is the future, or a few predictions that you might want to make in these areas?
I'm seeing a trend of a lot of effort being put into increasing access in healthcare. There is plenty of research being done and organizations who are creating all kinds of ways to increase access to healthcare by using telehealth, or by offering all sorts of health interventions through the internet. It doesn't even have to be telehealth, but giving information about health through just getting to customers through, for instance, WhatsApp messages, etc. But something I want to point out is that one has to be very careful to really understand, again, from the consumer's perspective, if you're going to highly underprivileged populations with all kinds of well-intended messages, whether it's about health or it's about access to finance, or it's about jobs, or it's education, and you're going through the internet, you need to be very sure that the people at the other end actually do have access. And you can say, well, they have a smartphone. But what we found, and this is in a research project that Alp Sungu, PhD student of mine, who is now an assistant professor at Wharton at the University of Pennsylvania, my alma mater, what we found is that in a randomized control trial that we did in Mankhurd, which is a highly underprivileged community in Mumbai, we found that, in fact, in India, for example, most data plans that are purchased by people who are quite underprivileged are not like the plan that many of us have, which is a monthly plan. You're actually paying for a month, but you have daily caps on the data. And so we tested by randomizing people into a daily plan versus a monthly flexible plan. We wanted to see what is the difference when you're sending out messages which are about health, etc. And we were inviting people to basically health camps, which we conducted in the slum, things like hygiene or nutrition, etc. And these are monthly plans people are buying. And what we found is that those who were in the more flexible plan, they were less likely to come to these health camps. And guess why? Because in the flexible plan, and these are often people who cannot read or write, they are burning their data on YouTube videos and WhatsApp video calls. And so by the end of the month, you finished your data. Even halfway through the month, you finished your data. Whereas if you have a daily plan, then you have a new lease on life every day, and you have the data. And so I think it's very important to do kind of joined up thinking. Don't just think that if you've got this fantastic health app or some way of getting people to start engaging in their own health, that's going to solve the problem. If they don't even have access to data, they have a smartphone, but they've run out of data. What are you going to do?
Yeah.
And so there, I think that it's great that we have these trends towards improving access, but you really need to take a higher level and look at what becomes the bottleneck for access. And then the other thing I also feel in terms of trends is that the world is we're not very accepting. There's such a diversity of characters and people of different kinds, and there's not that much acceptance. But what I feel is that even that is not immutable. You can change those things. So I'd like to share some very exciting research I saw, which was done in Turkey, interestingly, on the Turkey-Syria border. So it was Shule Alan and Ceren Baysan and some other economists. And what they did is something simple. They said, we want to study whether teaching children in schools to take the other person's perspective. So teaching them, it's not about empathizing. It's about, can I get into the other person's head and think like them?
You're not branding it as empathy, but rather how do you teach it as a core skill?
Right. It's not about if you're sad, I will also realize you're sad. It's more, why are you sad? Getting into your head. And with this training that they gave school children, and they did it randomly again to see what is the power of this training, what they found is that kids who had that training were more likely to have cross ethnicity, Syrian and Turkish. It was all on the Turkish side of the border, but there are Syrians on the Turkish side of the border, more friendships, which were cross ethnicity. And then also hard outcomes like better scores in some of the academic subjects. So this is super interesting. So I think that the way of the future should be to help people to make the world a better place.
Absolutely. And I think I really appreciated the idea, the overarching essence that you shared, which is to have joint thinking and to understand where the bottlenecks are in these services and to not look at them in isolation, but rather as conjoined factors in multiple avenues, which is where you shared the 2-3 examples, which were very, very eye-opening, I would say. Kamalini, this has been absolutely incredible. Thank you so much for joining, and thank you.
Thank you. Really enjoyed talking to you.